Good afternoon, colleagues and friends. Welcome to our 5th episode of series of Medical Live Zoom webinars on COVID-19 series. Those who don't know me, I'm Seta Bosian. I am a GP Principal Surrey Heartland CCG and Senior Advisor Advice Clinician on COVID-19 services. I'm also at NHS England. I'm also honored to be a chairperson of AMAGB, Armenian Medical Association, Great Britain. Thank you for everyone participating today and joining our webinar. And thank you for those who send us questions. We do every endeavor to answer your questions during this webinar. And special thanks to Armenian Community Council for giving us this opportunity to use Zoom in this for this series of webinars and also for their technical support. We are honored today to have with us two dental colleagues. As you know, it is a webinar on dentistry. Two dental colleagues. First is Dr. Sarah Balian. She is clinical and academic in dentistry since 1997.
It disappeared again. Yeah.
Okay. So the first speaker we have, Dr. Sarah Balian. She's clinical and academic dental surgeon since 1997. She worked in NHS and private specialty sectors. Sarah moved to teach in 2006 at King's College Hospital. And she worked there for 14 years, training clinical staff in dentistry. She has recently promoted and moved to Eastman Dental Hospital at UCH Trust as a program director for undergraduate training in dental therapy and hygiene. Our second speaker is, perhaps majority of you know him, Dr. Vahe Avanesian, who he is an independent, private, very busy clinical and cosmetic dental surgeon at Wimpole Street. And Vahe was one of our founder members of AMA in early 1980s, and he was our treasurer for long time until beginning of 2000. So thanks for Sarah and Vahe to join us today. So I would like to invite them in the platform to start. Sarah, would you like to start? Take the platform first, and then Vahe will join. Thank you.
Yeah. Thank you very much, and thank you very much for the invitation to speak today. When asked to present this, it actually gave me the opportunity to reflect what had been going on for the past 4 to 5 months, because within the hospital that I work in, I'm actually immersed in it all of the time. So I can only think about today and tomorrow, and I never get to think about yesterday. So this has been a really good opportunity. I think it's a good place to start in saying that dentistry in the UK, just giving a wider picture sort of view, is that dentistry within the UK is divided into two streams. And that's in NHS dentistry and private dentistry. And, you know, dentistry, despite its appearances, you know, as people who deliver dental care, and it doesn't matter where you are, what part of dentistry you are, whether you're a dentist, a nurse, a hygienist, a technician, it's fair to say that dentistry is so incredibly regulated. It means that basically we've got everybody on top of us all of the time in some way or another. And we can't usually make big national decisions, even if it affects our local practice on our own. So that's something just to keep in mind as I take you through this presentation. The other thing to consider is with dentistry, and the reason why dentistry has been so impacted, there's a number of points to consider, is the actual close proximity at which we are with our patients. We are dealing with the mouth, we are dealing with drills and water fluids that create what we term as aerosols. So basically, bits of equipment that we use in your mouth and actually creates a lot of airspace, or a lot of aerosol. And obviously with COVID being predominantly a respiratory viral infection, that's going to come through saliva and sort of breathing space. So that's also something to consider. The other thing to consider is that in the surgery, as I was saying to you before, is we're so incredibly regulated, is that when there's a term called infection control, we take a lot of measures to make sure that we reduce the transmission of infection from person to person, whether it's the team or whether it's the patient. But the other thing to bear in mind in all of this for medicine and dentistry, nobody wrote a rule book for this. So it's been incredibly, incredibly challenging, and actually we have to make decisions based on evidence, and the evidence in relation to this particular issue is exceptionally limited. So we're really stabbing in the dark with this. If we look back into March, just pre-lockdown, some dental practices were already starting to take measures in reducing the number of patients coming in. They were starting to think about how to control measures for patients who did come in, and then automatically lockdown happened. And lockdown happened, it was finished. There was no more practice. We went from busy practices, busy hospitals delivering care, to 0 patients coming in. So with that, we also have emergency dental patients. So, patients who come in pain, and we did not have provision as dental practitioners. We were in a position where actually we could not deliver anything to our patients, which is incredibly, as for us as caregivers, is incredibly challenging because we are so invested in the care that we deliver. Some practices were in a position where they could do telephone sort of phone calls, and the best way to deal with any pain that was coming through, we only had 2 options, and that was to prescribe antibiotics and give pain relief advice. And for us as clinicians as well, we're very conscious about the overuse of antibiotics because of antibiotic resistance, but that was the only option that we had. There are a number of sort of units that provide emergency dental services that had already been established, but they are very, very few and far between. Within London, I can even say there were only probably 2. And so as a result of not meeting the public demand in the pain that people were experiencing, emergency dental hubs were set up. Now, to do that is incredibly difficult, because part of the problem is that COVID-19, for a lot of practices, when we went into shutdown, and even in hospitals, we were asked to actually hand over a lot of our personal protective equipment, our PPE. So that's incredibly challenging, is to turn around and say, oh, we'll set up these emergency dental clinics, but now we have no protective wear whatsoever. So the organizations that were delivering the emergency dental treatment were best placed in hospitals, but the promotion of that and actually signposting people and practices to that was very, very difficult. And it was either through your local dental practice or through 111. But unfortunately, what had happened was, and what I felt following the press over the last few months, was that we were all watching the news. Medical news, dental news were coming up on the screen, on BBC continuously. There was no other news in the world other than what was happening with our COVID issues. And that's that's true for each country. But the problem is that I personally felt, and my colleagues felt, that actually what was being presented in the news was not a true reflection of actually what was going on. As clinicians, our hands were completely tied into what we could deliver. There was no one, unless set up for emergency dental services, no one could deliver dental care without actually getting signed off, without actually having very good reason to do so. And if they did, they were very lucky if they had the personal protective equipment to do so. So dentistry was brought to a halt, not because we wanted to sit down, kick our feet up and take a holiday, but actually because we had no equipment, but B, also we were very challenged with what guidance we had. As I said, we're very regulated as to what we could actually deliver treatment. Vahe, I might invite you to add something here at this point.
Well, first of all, thank you for having me. There's not much to add. I mean, there's a different perspective from a point of view of private dentistry. If you look at the crisis, the COVID crisis altogether, not just from the dental point of view, the dentistry comes really quite down low in order of priority for the government. They're much more concerned about intensive care units, having enough PPE for the frontline people, and then comes national health dentistry. Then right at the bottom, a tiny section is private dentistry. And as you said, there are several aspects to it. The most important aspect is that they didn't want to detract from giving PPE to the frontline people and asking private dentists to start getting PPE'd up to treat patients. The other thing is that as dentists, as private dentists, it became blatantly obvious that nobody was in charge of us. We didn't know who to follow. We didn't know who to listen to. None of the organizations, the British Dental Association, who's our union, couldn't help us. He said, we're talking to the government. The General Dental Council said it's not our thing. We can't tell you what to do and what not to do. We talked to the Care Quality Commission that are supposed to inspect us. They said, well, we'll come and inspect you. If you're doing something wrong, we'll prosecute you, but we can't tell you whether to work or not. And the chief dental officer is in charge of the NHS. So we were told that we should follow her, although she's not in charge of private dentistry. So it basically came down to talking to the people that indemnify us, or indemnity insurers, so to speak. And we had to listen to, if we start a practice and if a patient complained, do we have any legs to stand on? And they said, it depends on what you've done. So we didn't know who we're supposed to follow, who's going to tell us to do what. And a new association of private dentists was born to try and promote private dentistry. But it got to a point where a lot of my friends and colleagues, including myself, we decided we're going to open up and see what happens. Who's going to stop us? If anybody complains, then we'll worry about it. So we were actually really put out by this. And even financially, private dentists fell in between all the cracks possible. NHS dentistry, they were still getting some money because they had contracts with the government. So they were still getting some money from the government. We got nothing at all. If your profit before tax was below £50,000, then you got some help. You got about £5,000, which doesn't cover anything. We didn't get any business rates relief. The only thing we could do was furlough our staff, but that doesn't pay the landlord. So it was very hard. And also, a lot of NHS practices supplement their income from private dentistry. That is what allows them to actually practice NHS dentistry. With no income from that, how are you supposed to make it possible to practice?
I think it's really important to highlight, though, how NHS dentistry and private dentistry, although very separate streams, how actually they are so intertwined, because, I mean, this is a separate subject in itself. NHS dentistry is not sufficient enough to meet the needs of our population whatsoever. The framework in which it works in doesn't work very well, and that is very well known. It is up to private dentistry to scaffold and actually support the dental needs of the population. So actually, the both are very much intertwined, and it is very right that actually private dental practices were really left out in the cold on this one. And they about 4 weeks ago, before they started talking about opening services, the stats were leading to potentially 30% of practices across the country closing, and there aren't enough practices as it is, let alone have another 30% of them close.
Can I?
Yes.
Yeah. Can I make a comment about that? It seems that politically, this has been the aim of various governments over the years, mostly conservative governments, that they want to reduce national health dentistry to a core, very similar to the centers that they've set up. So you get people out of pain, you do some basic dentistry, extractions, simple fillings and so on, but you don't do anything else. So it's like an emergency service, if you like. They would love to do that because they don't want to fund NHS dentistry if they can help it. They'll get away with it. And this might be an occasion for them, a suitable excuse for them to say that we are going to reduce NHS dentistry to a core, and the rest of you go find either an expensive or a cheap or a medium price, sort of like an open market dentistry. So there's a lot of theory about that. Whether that's true or not, I don't know. But it certainly looks that way, that the government might take this opportunity to reduce the services provided by the NHS, which would be a travesty.
Absolutely. It will be the biggest downfall, because particularly at a time where we're talking about a holistic approach to care with medicine and dentistry, and we talk about how all of these medical conditions, diabetes, the impact on the oral cavity, on the mouth, and vice versa. Instead of moving forward and trying to integrate and actually take things that step further, it might turn around and say, actually, we're going to break it down, which would actually go against all evidence and all science, and really, really take us 10 steps backwards. I just did this sort of flow diagram just as a prompt, really, but also to say that, you know, during this time, when we went into lockdown, I've done a mixture of private and NHS dentistry, and I've moved into the hospital setting for a number of years now. And a lot of NHS practitioners, clinicians, dental nurses, dentists, no matter who you were redeployed. And actually, and what that meant was we had to go work in different sectors of anywhere, the sort of health service. So some people went into screening for COVID. I actually went into the maternity wing of all places. I had some surgical training, and all the junior doctors were going to be moved out of all the services, and so we got redeployed into the maternity wing. So delivered a few babies, not alone, I just like hasten to add. And then I moved on to the intensive care unit, where we were the family liaison team for those who were in the intensive care unit, because families could not visit their loved ones, and we were trying to ensure communications for loved ones and family members during that difficult time, which was really heart-wrenching. Some wonderful, fat, happy stories that can be incredibly emotionally challenging. But, you know, if you were in the health service or NHS factors, you could have been moved anywhere. So that included if you were in practice as well. But, you know, the emergency dental hubs, as I said, were not ideally set up. It wasn't a case of fix. If you ended up with toothache, it wasn't, we'll try and do root canal and try and save it. It was, the only option was, if you'd had antibiotics and you'd had painkillers, if you went into those hubs, the answer was you had to have the tooth out, which is not the way that we wanted anything to work, but it had to be at the time. There is a complete lack of evidence in regards to COVID and sort of measures that we can take place in the dental surgery. Some studies that were set up were very rushed, they weren't appropriate. And again, we're in that fact of we don't know that much at the moment. We had to try and preserve our PPE, and if we weren't preserving our PPE, we were giving it away. So if we wanted to get people back, we couldn't. But also what has happened is, because of now the population now having to take their own PPE, is that the price of PPE has gone up by 600%. I'm very used to my hospital masks, which we have to use. They're usually 20 in a box, and I think, correct me if I'm wrong, Vahir, they're like $2.90. They were $2.99 a box. They're now being sold at 30, 40, 50 pounds a box, and they're very difficult to get hold of. Part of the reason I'm also saying this is because when, as I said, we're regulated, we're dictated to by higher above powers nationally, is that when we were told that we could resume work on the 8th of June, that announcement was made the week before. Where were we going to get PPE with a week's notice? No one had any idea. Not for the volume of patients we were going to see and the type of patients we were going to see. We could not, even now people are struggling to get PPE. The other thing was classification of what we call AGP. AGPs are aerosol generating procedures. So the kind of gas that we create whenever we're drilling or doing cleaning teeth, you know, with the electric equipment. Bearing in mind, when you make the gas, it goes about 2 meters up and then it's going to come down. As you walk out the room as a patient, we take our gear off and we're going to breathe all of that in. And then we get our next patient in, and hang on, we're going to make the next patient breathe all of that. So you can imagine in dentistry, our work is very much hands-on. It is very much based on these, what we call aerosol generating procedures. And now we have to classify our 2 work streams, non-aerosol generating, i.e. it doesn't make the gas, or now this aerosol generating where it does make the gas. And on top of it, the protective equipment we have to wear is very different. If you go to the surgery now to go see your clinician, whether it's the hygienist or whether it's the dentist or whoever it is, if you're going to have any drilling procedure, they are going to be covered in head to toe in protective equipment with certain calibrations, with certain things, that's everything that needs to be certified. And that whole bit of equipment can range, depending on what the stock price they got it at, from £20 to at least £80, all of that kit per patient. It's also bearing in mind, as Vahir said, the private dental practices and a lot of clinicians, a lot of people fell into a big hole because mentioning that NHS practices got their contracts, but actually a lot of people within the practices are self-employed. That's some of the dentists are self-employed or associates, the hygienists are self-employed, and they fell through a massive gap as well. And that was also in the private sector. So you found that actually they were left absolutely out in the cold. But bearing in mind, for the past 3 months, there have been zero income into those practices to even buy PPE, to pay staff. As Vahir pointed out right now, it's where we stand. It's legally where we stand. What procedures can we do? What can we deliver? What measures do we have to take for people to come in, so that if ever anyone contracts anything, if anyone ever makes a complaint, if any of our regulators come and talk to us, we have to have a decision made. We have to have why we undertook what we did, and it's really, really difficult. We have, as Vahir mentioned, we have the Chief Dental Officer, which covers NHS sector. We also have the Faculty of General Dental Practice issuing statements. We had the BDA, we had the BSP, we had so many people issuing statements and then supporting guidance, that within 7 days, I think there must have been 7 documents of 100+ pages for us to follow of some sort of guidance. And still the messages were not clear. The communication streams were so incredibly poor. But the problem is that actually, when I said the chief dental officer announced we can all go back to work with limitations a week later, that's when the public found out, and that's when we found out as well. So we found out the same time that everyone else did. 7 days notice to train staff to get fit testing masks for the FFP3 masks, the ones that we have to use in aerosol generating. They have to be fit tested. Trying to get all of that equipment, you have to be trained to be fit tested. It was not enough notice. And even at the hospital, I sit next to some of our admin team. And because it had gone nationally that we could open up shop, and that's the way it was presented, was that patients were phoning and complaining, saying, but I heard on the news that you can come back to work. You can see me now. Stop being so difficult. We really were stuck in a very challenging position. But what it has given spark to are a number of things. And I recently did a webinar, for a series of webinars for the BSP, the British Society of Periodontology. And what it's done for some sectors of dentistry and some specialties of dentistry, such as orthodontics and periodontics, sort of gum health and braces stuff, is that it's given us a platform to move to e-dentistry. Now, not all bits of dentistry will be able to do that, but we've been doing telephone consultations and actually doing video dentistry, because part of the reason why is you have to minimize the time in the surgery. When I talk to my hygiene team, is that actually whatever advice we're giving to the patient, we're going to do on the e-dentistry platform. We're going to do it on video before the patient comes in. And when we get the patient in, the main focus is hands-on dentistry. You have to minimize the time in. So when you go to the dental surgery now, it's a very, very different place. Vahe, I don't know about you, but we've limited the number of people who can go in waiting rooms. People have to wait outside to be phoned in. And actually leaving bags and bags and coats and everything outside of the room. People have to walk in with masks. And every practice has to have their own guidance. I don't know if you want to jump in at this point.
Yes. So while we couldn't practice dentistry, I was envious of my NHS colleagues who had some income. But now that we're sort of back, so to speak, I really feel sorry for them. Now, there are several aspects to all this PPE and infection control and so on. So what I would like to mention first of all is that before COVID-19 arrived, we were already very aware of the various things that we can catch, because patients open their mouth and we stick our nose in it. So there are things like hepatitis, which is much hardier than any virus. It can sit on the side for months, if not years, and then activate when it wants to. So we were already pretty PPE'd up. Now, wearing PPE is not for the protection of the patient. It is for the protection of the dentist and his staff. So to transfer viruses from one patient to the other is quite difficult. It's possible, and that's what we were talking about, the aerosol that's generated. So now you're supposed to leave an hour in between patients for the aerosol to settle before you wipe the surfaces. Now, where did this 1 hour come from? Nobody can tell you. There is no clue as why an hour. Why not 15 minutes? Why not 2 hours? Why not 20 minutes? Nobody knows. So what they're saying is that dentists are clever people and they should work it out for themselves what they think is reasonable. Now, will that stand up in a court if somebody comes and says, I caught the virus in your surgery? I don't know. They say if you can open windows, if you have air conditioning that sucks the air out, if your room is such and such a size, and so on. Nobody knows. And the other thing we don't know is that this aerosol that's generated, they worry because there's saliva in the aerosol. That's why people worry. If there was no saliva in the aerosol, why would you worry? It's just aerosol. Now, how many patients breathe through their mouths while you're actually drilling? Well, virtually none. So how much saliva gets into it? How far does it spread? So what is happening in practices such as mine is that we have to risk assess the patient. That's why now every patient that turns up at the list, we need to have answered questions before arriving and questions when they arrive. That they haven't had temperature, they don't have a cough, they're not aware of any tiredness and so on. Then on top of that, we look at their age. If somebody is above the age of 65, 70, there's a good chance that if they had it, they would know they've had it. They cannot be silent carriers. Then you take their temperature. I also give them a test, which is not very accurate, but it's just another way. So I test antibodies in the surgery if patients are happy to have that done. So you risk assess. And at the end of the day, if you think the risk is too high, you either don't treat them or you go for full PPE. And the cost of the PPE is not just the dentist, but it's his nurse as well. There are 2 people minimum that have to be PPE. Plus, if you have a receptionist, they have to have masks and gloves and so on. So it's not just one person. The other thing about PPE, and that's where the private and national health differ, is that in national health, everything gets binned. In private, I would like to see the evidence of why we're binning everything. The COVID-19 doesn't survive on any surface more than a week. So a 6-pound FFP3 mask that has to be fitted, and if you change the brand, you have to refit it. Why are we binning it? Can anybody give me a scientific reason why? So what I do, I label all the masks that I use, and we keep them in a separate room for a week. And we have the name of the patient as well. If it's a low-risk patient, I haven't generated too much aerosol, and I'm happy with the condition of the mask, it hasn't deteriorated, I reuse it. And I can't see any scientific reason why not. So there's a lot of unknowns. They say you may or may not be able to catch the disease twice. Well, there has to be a point in life where you say, okay, you've caught it, you've recovered from it, live a normal life. Otherwise, we'll be here for decades. So it's a matter of risk assessment. As far as the costs are concerned, I think one of the questions that we have is that dentists are trying to pass the costs on the PPE to the patient. And I'm thinking, of course they are. It's for the protection of the patient and the dentist. It's a two-way street. So why shouldn't they pass the cost on to the patient? When you go to buy a car, you pay for the safety belt. It doesn't come as an extra. So it is a different environment. It's a different world. And some patients get really annoyed when you ask too many questions, but that's how it is.
Absolutely. And it's not going to be that they get asked it once. Every time if they do have a revisit, they have to have the same set of questions again. So it's going to be constantly repeated.
Yeah.
But I also think it's worth mentioning that much like medicine and actually nursing, is that we are going to have this knock-on effect. This has also impacted dentistry in another set of ways, in that it's delayed some training. So the training of our future generation of clinicians has been delayed, which means that actually those who were going to deliver care won't be in a position to deliver care when they were supposed to. So there won't be enough clinicians about. But what COVID has done is actually moved people out of our profession. So we've had a massive reduction of our dental service because people have decided to take early retirement. People have decided to leave the profession entirely. And that's through the uncertainty of dentistry and what it posed, but also because some people actually discovered that they found new areas that they just were far more interesting in redeployment. So it's going to be an interesting time, but this is not going to impact us for the next year or couple of years. This will take nearly a decade, I think, to come out of, particularly if we have to hit a situation where we have to stop serving the public again. The reason why you cannot have all of your dentistry done now is because we've been asked to deal and prioritize treatments. We have been asked to go through our patient list and say who is in dire need of treatment now, whose treatment will impact them, particularly from a health perspective, going down the line. Because at the moment, we were, until about, I think, 10 days ago, we were classified as level 4 high alert. Therefore, we could only really do emergency care. We've been downgraded to 3, but that actually doesn't change the amount of treatment we can deliver. We're still very limited to what we can do. What this has done for us, though, is I attended a webinar on the health behavior changes for chronic diseases like diabetes, what have you. And, you know, dentistry is very much honed in on self-care, and we don't do enough promotion of that. We don't tell enough and spend time enough with our patients on actually self-care. And through all the sort of guidance that we've had recently from our societies and above, the first phase of care has to be behavior change. So basically, before we can really put our hands on you, is have we given you the advice to actually undertake the home care that you should do? And it's no different than if you're a diabetic and you've got to take control of your diet and lifestyle factors. It is exactly the same thing, because before you come in, we need to get those bits of you looking after your mouth, you know, a lot better, and then we can get the treatment done. And that's the way it's always been. But actually, we're using this is a really good time to make sure that that's as best as it can be. So that's why I'm at this here. You can see it says coaching online, because actually we've moved to doing a lot of that coaching, taking people into the bathroom with their phones and actually doing all of that advice at home. But it is a phased return. Until things are downgraded, we will be limited to what we can deliver. We won't be accepting, I don't know more in the private sector, but for us, if it's not urgent, it won't be happening. Because right now we still have to preserve our PPE for potentially a second wave. We still have to do a lot of training, and we've still got all these regulators to follow. So at the moment, when you go into the dental surgery, this is pretty much what you will see. And if not, there's some of them even look more sort of garish and scary. But they will be covered from head to toe. And as I have said, there has to be some downtime. If you're not having a procedure that generates the gas, the aerosol, then you might be able to come into the surgery, you know, with more patients coming in more frequently. But if you're having that gas procedure, which is the drill and the ultrasonic, the scaler, then we have to have some space time, which means that historically when I saw patients, I'd see 16 patients in a day. You'd be lucky if I can see 5 now. So it's a very interesting time in dentistry. And so what I'd urge you to do is have some patience, but also understand that it's the treatment that people can deliver at the moment is limited.
Well, in private dentistry now, I think people are going back to work and they're delivering the full range, because obviously we don't have thousands of patients on our list, we have hundreds. And if we just did basic dentistry, we might as well not go back. Private dentistry is slightly different. But it does change things in that if you dress up to do a procedure, let's say a checkup that doesn't require dressing up in your full PPE, and then at the checkup you find that they need a filling, so now you need to drill. Then you have to get changed. Then you have to put full PPE on, and if there's a patient after that, you have to cancel them. Or you have to send the patient home, say, make an appointment, come back, and I'll do this filling then. So, well, can't you do it now? I said, well, no. So it's going to be a different way of practicing.
Great, great. Shall we start answering the questions we have received, Sarah and Vahe?
Sure.
Would you like to take the first question, Sarah? Would you like to read, or you want me to read the first question? You are muted, Sarah.
Sorry.
Yes.
Is this the one in the email, or?
Yes, the one starting the one from the emails, and then we take from the participant today.
Okay.
Which says, is it safe to use a water-based plug removal? And if yes, how best to sterilize it after use?
So my interpretation of a water-based plaque remover, which would be something like the water jet, is my assumption, is that there's nothing wrong with using it, but it would not be the only item that I would be using. Is that toothbrush, toothpaste, and flossing and the little interdental brushes are absolutely vital. The water product is not a replacement for any of those. It is just an extra. You can't quite sterilize it, and I don't know what units that we're talking about, but for me it would just be soap and water, and that's pretty much all you can do with it.
Great. Vahe, would you like to add anything, or you are happy?
Yeah, this sterilization
compliment
thing,
what Sarah said.
Yeah, this sterilization thing I think is a bit over the top. You only need to sterilize something if you're getting invasive into somebody's body. So if you're doing open heart surgery, you sterilize things. Otherwise, all you need to do is make it clean enough so that if somebody else is using it, you do not actually pass anything to them. But that should have been the case before the virus anyway.
Right. So how safe is to, in terms of the COVID-19 point of view, is to visit dentists now?
Depends on the dentist.
I think that's a very good answer.
It's a long string question.
On the NHS, I think is pretty safe because the guidelines are very strict. Mm-hmm. I think on the NHS is pretty safe. Privately, we're scared of being sued. So the vast majority of dentists will stick to the letter of the law. They will use all the correct procedures, and that's the maximum we can do. So it is pretty safe. Statistically, a dentist will come across somebody with an infection 3 or 4 times a year, depending on how many patients you have. In my case, it'll probably be once a year. In a busy NHS practice, maybe 5 a year. So statistically, to come across somebody who's actively infectious is very low. And also, most of the time, they would know, so they won't turn up. So statistically, it's pretty safe.
Good, good. So you can reassure people if they have emergencies not to wait to start attending. Okay, shall we go to the next question in the email, which is, how will things be different during a dental appointment? Will certain things be necessary or not possible?
I think I've covered quite a bit of that, in that if you're in pain now, that you will be seen, but it takes careful planning, particularly if they're going to do a procedure which requires the drill and requires aerosol. But yeah, I think until they get downgraded, they are limited to what they can provide. So if we're talking about something that's cosmetic and elective, i.e. you don't need it out of emergency, the likelihood of that happening is pretty minimal. We were having a debate the other day on a webinar because, you know, hygienists at the team that I teach, they obviously deliver treatment, and they're limited to what they can do. They can't use the electric scaler at the moment. They've got to go back to hand. and so do it manually. And there was a question about polishing, which is a pleasure to have. It's not a vital thing, but it is a plaque removing product and something that takes off stain. And there's been big debates whether they can have it or not. And it's only recently, in the last 5 days, actually, I think the statement was issued on Tuesday last week, that actually they can carry it out, but only very limited with certain conditions. So we are limited in our sector as to what we can deliver at the moment, is the answer to that. But before anybody goes to their appointment, a practice would be giving them a briefing, would be giving the patient a screening. My daughter attended her appointment the other day and I wasn't allowed in. I had to call them, I had to fill out a form before going, I had to stand outside in the rain, and she was invited in and went for her appointment, and then had her alcohol gel. She went in, you'll have to alcohol gel, we'll temperature screen you, we'll do all of these things before you actually go into surgery. You're not allowed to use the bathroom, you're not allowed to get a drink of water, all of these sorts of things.
So it's not, life is not very easy nowadays with any medical attendance.
Nope.
However, we are encouraging, as you said, you are seeing 5 instead of 16, 17, and you certainly would like to see more. However, with those difficulties, it's very difficult for them to attend.
Yeah,
great, absolutely. Thank you.
Yeah, I think to add to that is that if you're going to see it, talking about private dentistry now, you might not be able to get the appointment at the time you want, because we have had to space the patients out. Also, talking about people accompanying other people, if you do end up in the surgery because you've got a minor in the chair, they have to have a face mask and they have to have a face shield as well. And that's to protect us, because the patients live together most of the time. That doesn't really bother them, but it bothers us. So they have to be wear protective stuff. And yes, we don't allow the patients to go into the waiting room. They come straight into the surgery. And from the surgery, they don't go anywhere else. So now, whereas before I would take the payments and give the appointments at the reception, now everything happens in the surgery. We don't want them wandering around the place. So we move the payment machine into the surgery, and we've got a computer in the surgery, so we give the appointments there as well. So we restrict the amount of places that the patients move. And we try to make sure that they don't actually meet each other in the hallways and so on.
Great, great. Shall we tackle the next question, which is, will there be any additional requirement on patients? Which I think we mentioned briefly, you mentioned that, but if you could elucidate more. It says a friend of one of my sister said she'd been charged for the dentist protective clothing. So is that what you do also, Vahe?
Yes, I do, but this is not new for me. So there are 2 ways of doing this. Either you put all your charges up by X number of % to cover all the extra things, or I have, for the last 5 years, I've always had an extra charge. That is for all the disposable and all the things we have to do to comply with the regulations, by the Care Quality Commission, GDC, and so on. Because now we've got more bodies supervising us. They're all charging us monthly fees to do that. And I can't see why we should pay for it. Because all of the things that they want us to do, the way we use the sterilizer, the way we have so many sinks in the practice, where we wash one, where we wash the other. And to actually comply with that, my nurse has to spend hours and hours and hours filling in forms and reports every month. So somebody has to pay for it. And it's usually the person who gets the service that pays for it. So I can't see why they shouldn't. So for the last 5 years, I've had an additional line that says, in order to comply with the CQC regulations and disposable costs, we add X amount. And the amount changes according to what disposables we've used. So if it's the usual disposables like the suction, the gloves, the mask, and so on, that's fine. But if it's more complicated, because I have disposable hand pieces, and I've got disposable instruments. So I have to throw those away, the cost is more. And now we've added a little bit more to it because of all the PPE we have to use. So
Right.
it changes from £15 to £25 to £35 depending.
Right, but do you have a set fee which be regulated or provided to you by your General Dentistry Association?
No, general private.
Or just like what we get from a BMA, set private fee from suggested fee, which we receive sometimes from BMA.
No, no. The private dentists they can charge what they like.
Right.
And it's regulated by the market. So
Okay.
if you're working and people are happy to come and pay you £10 for a filling or £50 or £100, that's what you charge.
Okay.
And usually you get a balance. So the people who are not happy to see you and pay that amount of money, they won't see you. And I know
Right.
this is not a very ethical way of explaining this, but it's like going and buying your clothes. You can go to Primark and buy a t-shirt for £5, or you can go to some upmarket boutique and pay £45.
Yes.
It is what you think you want to pay. And
right.
we are not in a position to force patients to come and see us. I can understand on the NHS that these are the people that want to go and see an NHS dentist. They don't have a choice. With us, they have a choice. Where I work, there are 350 dentists. So if I was the only one, I'd be a millionaire, but I'm not. So if they don't like my prices, they don't like my services, they don't like the way I talk to them, they don't like the pictures I have on the wall, they go next door.
So it's competitive.
It's like anything else in life. Why would you go to one hairdresser, not the other one? Why would you go to one restaurant, not the other one?
Yes.
So it's an open market.
Okay, that's great. Thank you. Thank you. Now, the other question came in. It says, is there any alternative to temporary tooth repair kit for tooth filling?
No.
Is there anything?
No.
There are, you can buy in pharmacies or online, you can order temporary treatment kits. That comes with a paste.
Right.
And you squeeze the paste in the hole and it's set. But you have to know why you've got a hole in the first place.
Right.
So if it's if you've got active decay, do you want to put some temporary filling in it and then wait 6 months?
It'll just get worse anyway.
Yeah. So in reality, no. There was another question about temporary cementation of a crown. I don't know if that's the same question or not.
I think we're coming to that one.
Oh, okay.
With the crown. The other question is, how long the NHS dental service can remain closed? It's not closed now, no? It's opened. Right. And what is the perspective for reopening NHS dental services, which is opens? Would you like to answer that one, Sarah? What is the solution? It says the continuation of this question. What is the solution for dental treatment when the NHS dental services is closed for uncertain time? Private self-management, or what's the other?
There's a couple of things to consider. Is if there's the dental services as from the 8th of June should have started to reopen. They didn't reopen all full and glory. They opened with limitations. So now things are at alert level 3. They're still at the point where they're limited to what they can deliver. We're only hoping that the level alerts are going to go down, and then hopefully we can go back to what is inverted commas as normal. But what I think the question should be phrased at is if we shut down again, how are we going to manage it this time? Because we've learned a lot this time around from knowing nothing. And hopefully and God forbid we go into lockdown, if we go into local lockdown, whatever that looks like, is that we need to be prepared of how we're going to manage it differently. And I think there's a lot of lessons learned, and just to know that the best thing to do at this point is, if we do get in that position, is to get to one of the emergency dental hubs. And the way to do that is either phoning the practice and they refer you, or 111. And that's the only thing that can happen. If we go into lockdown again, the hospitals will shut as we shut. We were very limited to what we could do. We opened an emergency dental service, and it was 3 main hospitals in London that were doing that. So that's the only thing we can do. If our hands are tied, our hands are tied. We can't go against it, because the ramifications of it are far too high.
Yes, yes. Well, we had considerable number of calls came through in early days, dental calls through not only ordinary 111, to call 111 COVID services, where it just for antibiotic prescriptions. They had no choice just to have antibiotics because they can't get through the dentist. Yes. Okay, shall we move to the next question, which is, it says, can one go ahead and start having complicated bone graft dental implant now, or is better to wait? What are the risks versus benefits?
My answer to that is nobody's going to be doing those at the moment.
No. And how much cosmetics are you doing, Vahe, nowadays?
Well, actually, this bone grafting and so on, I'm happy to do it. I can see why they don't want to do it on the NHS, because they have to prioritize.
But they don't do it on NHS. They normally don't do it on NHS.
Yeah, in the hospitals they do.
Yeah, all right, yes.
Yeah, so as far as I'm concerned, it's either safe or it isn't. So if it's safe to do a filling, then it's safe to do bone grafting. So that hasn't really changed. If you're going to put PPE on to protect yourself mostly, then whether you're taking a tooth out or whether you're drilling or whether you're putting implants in, it doesn't make any difference.
Right. Oh, that's interesting to learn. Great. And there is one more. Well, I think there are two or three more questions. The one is says, when this is the one with the crown. When a crown comes off and we are unable to get a dentist immediately, what do we do? Can we glue it? Can we do self-management?
Okay, so if the crown fits snugly back on and it's come clean off, in other words, you haven't got a crown with half the tooth inside it, then if you just want to put it on for a short period of time, you can use denture adhesive. And you can buy it in all the pharmacies. If you buy denture adhesive paste, that might keep it on, and you might have to reapply it twice a day. But that will keep your crown on until you see a dentist. But again, it depends on why the crown has come off. If it came off because you were having a sticky toffee, then the chances are that you can put it back on. But if the crown has come off because something is broken inside or there was decay underneath, then you won't be able to put it back on. But do not use super glue. It's actually got cyanide in it, so you don't want to be using super glue.
No. And there's nothing medicated super glue like in the market now.
Not that I know.
No. Okay, great. Thank you. There's one more, actually two questions in the here in the chat box, which is one of them is, are there any preventative measures we can use on top of brushing, flossing, interdontal brushes, etc., e.g. salt water or rinsing?
So from my perspective, it's doing all of those things very well and doing them twice a day. Although we haven't got, admittedly, if I was to stick to a certain routine, my routine would be brushing twice a day. One of the most important things, and this is something I repeatedly say to patients, is do not rinse out immediately after you brush. Spit the toothpaste out, don't rinse it out, because actually the toothpaste is incredibly powerful as a medicament. And then don't use mouthwash immediately afterwards either. So it's brush your teeth and spit out. The flossing and the interdental brushes, as long as you do them very well, as long as you've got the right sizes. And I always say to my patients, always do them in the evening, because that's the best time to make sure that these things, like all the food and plaque, is removed from the mouth. And then the suggestion is saltwater rinsing. I'm not an advocate of saltwater rinsing unless you've had some sort of tooth extraction or some surgery. It's nothing, it wouldn't, for me, add any health benefits. And I think there was an additional comment about the thought of the Ayurvedic oil pulling. It's a very interesting subject, and actually, the oil pulling, scientific, has no evidence base behind it. What evidence there is for the oil pulling is that if you did it for 20 minutes, then it might have some health benefits. But my argument would be are you going to sit there walking around the house in your bathroom for 20 minutes with a concoction of water and oil, when actually you could take a 5-minute routine with your toothbrush, your toothpaste, and all of your bits and pieces and do it that way? For me, it adds no health benefit whatsoever and takes a lot of time. So for me, it's a good toothbrush, making sure that's at its optimum, spit the toothpaste out, don't rinse it, and use all of your bits and pieces around that. So that's the most important thing.
Great.
Yes.
The formula for your home care does not have to be complicated. And the argument that I say to my patients, do it once, do it well in the morning, do it once, do it well in the evening. And you know what? The mouth can cope, but you've got to do it right. And the mouthwashes and I'm going to say it because I have an audience, is that, you know, if you see bleeding gums, that's not normal. For some reason, that is very socially acceptable. I have bleeding gums, or let's deal with that. You know, we'll ignore that. Bleeding gums isn't normal. And we naturally gravitate towards a medicament on the shelf. We'll go for the mouthwashes, you know, we'll go for certain products that says heals bleeding gums. It's the cleaning routine. It's the physical contact, which is so important. And it's only when I have a group of patients that really struggle with home care do I say use the mouthwash and all of these things. But physical removal, do it once, do it well in the morning, and do it once and do it well in the evening. And it works really well. Sorry, I love my little soapbox about cleaning routines at home.
Very good, very good.
Is there time for me to say something about that? So again, if you're going to approach this scientifically, it is not the sweets that make the holes in your teeth. It's the bacteria that use the sweets that make the hole in your teeth. So as soon as a baby is born and then you lick a spoon and then put it in the baby's mouth, you infected it. So if you're going to brush your teeth, scientifically speaking, you should brush before you eat. If you manage to remove every single bacteria in your mouth, which is not possible, but if you could, you can eat as much chocolate as you like. So officially, you're supposed to brush before you eat. Once you've eaten, your mouth gets acidic. Once it's acidic, your enamel is dissolving. So if you brush straight after eating, you're actually taking your enamel away. You have to wait 20 minutes, half an hour, before your mouth becomes neutral, before you can brush. About flossing, 9 out of 10 people do not have the manual dexterity to use the floss correctly. And the 10% that they do, the floss is only effective on front teeth. On back teeth, it does very little. Interdental brushes, excellent. As far as Ayurvedic medication is concerned, if Colgate doesn't make it, you don't need it. Everything that big companies like Colgate, Sensodyne make, they have to prove scientifically that it has benefit. And if Ayurvedic medicine oil pulling had it, they would have marketed it by now. If they don't, it's because they can't scientifically prove that it's beneficial enough to sell it to the population. Sorry about that.
Yes.
I feel quite strongly about these things as well.
We're on the same page.
Yeah, well, that is great. Let me see if there is any more question or any. I think we covered most of the questions. I can't see any new question here in the box. Great. Well, what's left for me to say, thank you so much, Sarah Balian and Vahea Vanessian, for this interactive, fascinated information during presentation and during the question and answers. Great. I mean, I personally enjoyed very much and learned a lot, and I'm sure our audience did the same. Thank you for all those who participated. As I mentioned before, and I'm mentioning again, your feedback is greatly appreciated. Please, if you could submit, as this is the way where we can improve our webinar sessions. And as I mentioned before, and I'm repeating again, we continue doing this sort of COVID-19 impact or effect of COVID-19 medical webinars bi-weekly. And I am pleased to announce that our next one will be on the 12th of July, and it will be a subject's medical legal aspect. The impact of COVID-19 on medical legal problem or issues, which the lawyer Tenny Shanyan from British Armenian Law Association, she kindly agreed to, with her colleague, to present and also to answer any relevant questions come today from audience. I think that's all what I would like to mention now, and thank you so much for you again. Thank you for all the participants, and thank you for Armenian Community Council again, and for providing us this platform, and also for their technical support. Well, I wish you a very happy rest of the weekend if you have. I know how busy your schedules are, and hopefully all the services will go back to normal, and we will not have second wave if we stick with the all the safety measures. Thanks a lot. Thank you, Sarah. Thank you, Vahe.
Thank you.
Thank you.
Thank you.